In this disease, students, patient is exposed to pigeons and there can be an allergic reaction, and what is this called as? Bird fancier's lung. This is a kind of hypersensitivity pneumonitis. Write down hypersensitivity pneumonitis. It is also called as extrinsic allergic alveolitis. Extrinsic allergic alveolitis. Then this is characterized by type 3 and type 4 hypersensitivity. It is characterized by type 3 and type 4 hypersensitivity. Because there is no type 1 hypersensitivity, serum IgE levels will be normal. There will be no peripheral eosinophilia. There will be no peripheral eosinophilia. Serum IgE level normal and there will be no peripheral eosinophilia. And when you take a biopsy, one can notice non-caseating granulomas, bronchioles filled with inflammatory cells. Cellular bronchiolitis means bronchioles are filled with inflammatory cells, and you can notice interstitial inflammation. Now, what is this disease? Extrinsic allergic alveolitis. This is an allergy. It is coming from outside. Which part of your lung is involved? Alveoli. Whenever I say there is some allergy happening in your lung, what is the first disease that will come into your mind? It is generally asthma. Now let us see the presentation of asthma. For example, allergen reaches your bronchus. Your bronchus is not liking that allergen, so there will be bronchospasm. Because of bronchospasm, immediately patient will develop symptoms, and if I put my steth, there will be wheezing. And asthma is type 1 hypersensitivity. Within the blood there can be increased serum IgE, increased eosinophils. These are the three important features. Now let us compare with hypersensitivity pneumonitis. Here it is not the bronchus getting involved, it is the alveoli. For the allergen to reach the alveolus and to cause inflammation, it will take some time. So symptoms will not be immediate, it will take some time. So it will be after 4 to 8 hours. And here, because alveoli are getting inflamed, so these inflamed alveoli will close at expiration. During the next inspiration, they open with a popping sound. What is that popping sound called? As fine crepitations. And this is type 3 and type 4 hypersensitivity. This is not having type 1 hypersensitivity. So serum IgE and eosinophils will be normal. Asthma, immediate symptoms. Hypersensitivity pneumonitis, it will take some time. Asthma, wheezing. Hypersensitivity pneumonitis, more of fine crepitations, because inflamed alveoli can close at expiration. During the next inspiration, they open with a popping sound. Asthma, serum IgE, eosinophils can be elevated. In hypersensitivity pneumonitis, they can be normal. This is a differentiation between asthma and hypersensitivity pneumonitis. For your exam, they will ask some examples of hypersensitivity pneumonitis. Very important table. The various diseases we have. Former's lung. First is former's lung. Former's lung. The source is moldy hay. The antigen is micropolyspora fini. Then we have Beggasosis. Here it is due to sugar cane dust The antigen is thermoactinomyces saccari. These two belong to the same family called as thermoactinomycetes. Now in the question, if they ask thermoactinomycetes can cause farmer's lung, is it true statement or false statement? It is true statement, because both belong to the same family. Then we have malt worker's lung. This is due to moldy barley. An antigen is Aspergillus clavatus. Then we have the famous bird fancier's lung. It is because of pigeon dust. And the antigen is protein in that dust, avian protein. The recently asked hot tub lung, source or exposure is contaminated water from hot tubs, and the organism is Mycobacterium avium. It is due to Mycobacterium avium. For your exam, important will be farmer's lung, Begossosis, bird fancier's lung. What will be the diagnostic criteria for hypersensitivity pneumonitis? The most important diagnostic criteria is history of exposure to any one of this offending antigen. Patient should tell you, or there should be possibility of exposure to any one of this offending antigen. So write down diagnostic features. First is history of known exposure, capable of causing hypersensitivity pneumonitis. Pigeons very dangerous. Second, presence of serum precipitants. Serum precipitants means antibodies. Your body is not liking the antigen, it is producing antibodies against offending antigen. History of known exposure, presence of serum precipitants against offending antigen, occurrence of symptoms in 4 to 8 hours, recurrence of symptoms on re-exposure. If you put years death, there will be inspiratory crepitations. Now if this exposure continues for longer duration, because of chronic inflammation, there can be weight loss. Patient will have weight loss. So the diagnostic criteria, these are the features. History of known exposure means antigen which is capable of causing hypersensitivity pneumonitis. Presence of serum precipitants against offending antigen. Occurrence of symptoms 4 to 8 hours. Recurrence of symptoms on re-exposure. Inspiratory crepitations, weight loss. Now coming to the treatment. Most important will be avoidance of offending antigen. If your body is not liking pigeons, you should not go near pigeons. And this everything is also some hyperinflammatory or hyperimmune response. To bring down that hyperimmune response, steroids will be helpful. Treatment include avoidance and next course of steroids. This is regarding hypersensitivity pneumonitis. Next let us see In this disease, there is predominant involvement of interstitium that can progress to lung fibrosis. What is this disease involving the interstitium progressing to lung fibrosis called as ILD? I call it as interesting lung disease. Let us see what is interesting here. The definition: ILD is generally characterized by predominant involvement of interstitium, that can progress to lung fibrosis, which vary in mechanism and magnitude. See the definition, students. Here the predominant involvement is interstitium. Later air spaces can also be involved, but predominant involvement is interstitium. The end result is lung fibrosis. Will the lung fibrosis be same in all? No. It varies in mechanism and magnitude. Few will have mild fibrosis, some can have severe fibrosis. Those with severe fibrosis generally will have very poor prognosis. Coming to etiology of ILD. This can be classified as inhalational ILD, the first group, inhalational ILDs. This can be either due to organic antigen, inhalation of organic antigen. Just now we have discussed hypersensitivity pneumonitis. Inorganic dust, such as asbestos, silica. Next group, it can be due to drugs or radiation. Drugs such as nitrofurantoin, amiodarone, busulfan, bleomycin. These are various drugs that can cause ILDs. Radiation can also directly involve the interstitium and result in ILD. Then we have connective tissue disorders. These connective tissue disorders such as rheumatoid arthritis, SLE, scleroderma, as a part of systemic involvement, they can directly involve the interstitium and cause interstitial lung disease. Then other systemic disorders such as sarcoidosis, inflammatory bowel diseases. What are the inflammatory bowel diseases that you know, students? We have Crohn's disease and ulcerative colitis. In these inflammatory diseases, as a part of systemic involvement, this inflammation can reach the interstitium and lead to interstitial lung disease. And ultimately, when you don't know what is the exact cause, what is that group called as idiopathic group? As of now, idiopathic group is considered as most common group responsible for ILD. In ILD, these are the various groups. It can be either because of inhalation, it can be due to drugs or radiation, it can be due to connective tissue disorders, it can be due to systemic disorders, it can be due to idiopathic group. Now coming to investigation of choice. Investigation of choice for interstitial lung disease is HRCT chest, high resolution computed tomography. Now if they ask you confirmatory test, your answer should be lung biopsy. Confirmatory test, your answer should be lung biopsy. But if they modify the question like this, most effective method of diagnosing ILD, write down this statement from Harrison. It will be a multidisciplinary. In majority of institutes there will be ILD panels. Those ILD panels will be containing a physician, radiologist and a pathologist. They will discuss among themselves and they will come to a conclusion, because ILD is a difficult disease to identify and treat. That's why there will be a ILD panel in majority of the institutes. The physician will give the clinical data, the radiologist will give the CT chest data, the pathologist will tell you the biopsy data. Putting together, they will discuss and come to a conclusion. This is considered as most effective method of diagnosis. But unfortunately in our country, whenever we say a panel discussion, majority remember such panel discussion which is of no use to anybody. Which is the most important panel discussion that you should do? You should do a multidisciplinary discussion for finding out what exactly is happening in this patient, because investigation of choice for ILD is HRCT, CT chest. First we will see the radiological pattern. Confirmatory test is lung biopsy. Then we will go into the pathological pattern. Write down radiological pattern of ILD. Radiological pattern of ILD. Radiological pattern of ILD. First of all, when do you suspect it to be an ILD? Patient can present with shortness of breath, dry cough, and when you put your stent, there can be fine crepitations. If these are present, one can suspect it to be an ILD. And if you send to a chest X-ray, what do you notice? In the chest X-ray, you can notice bilateral reticular pattern, some bilateral haziness. More than this, it is very difficult to identify on a chest X-ray, bilateral reticular pattern. So for better visualization, you are going to take a CT chest. If at all I draw anything like this, this is axial section of lung on a CT film. If you draw anything like this, this is axial section of lung on a CT film. The initial findings, there can be very mild haziness. I told you what is this mild haziness on a CT chest called? We have discussed in COVID. It is ground glass opacity. Or there can be more increase in density. This more increase in density, it is called as consolidation. Either ground glass opacity or consolidation can be evident. But what is the end result? There can be fibrosis. Where the fibrosis predominantly happens? Interstitium. Because of ongoing interstitial fibrosis, this patient can develop traction bronchiectasis. Already we have discussed the mechanism of traction bronchiectasis in bronchiectasis. Now in advanced ILD, now what can happen in advanced ILD? There will be more and more fibrosis. In advanced ILD, there will be deposition of dense fibrous tissue around alveoli. There will be deposition of dense fibrous tissue around the alveoli. Because of that, alveoli will be like abnormal rounded areas of air at the periphery of the lung. Because of dense fibrous tissue getting deposited around the alveoli, so it will appear like abnormal rounded areas of air at the periphery of the lung. This indicates there is severe architectural distortion of lung parenchyma. There is dense fibrous tissue deposited around the alveoli. Now this alveoli will appear like abnormal rounded areas of air at the periphery of the lung. This phenomena is called as honeycombing. Honeycombing indicates there is severe architectural distortion of lung parenchyma. Now out of this, which is generally associated with poor prognosis, I am giving the red badge. Red means poor prognosis. It is honeycombing. Which can be associated with good prognosis, the green badge. It is ground glass opacity, because ground glass opacity is just mild haziness, whereas honeycombing is severe architectural distortion of lung parenchyma. Patients with honeycombing will have poor prognosis. With the ground glassing might have good prognosis. Let us see some imaging findings. Now the first image, what do you notice here? There is mild haziness only. When compared to surrounding lung tissue, it is only mild haziness. This mild haziness is called as ground glass opacity, whereas here there is more increase in density. This phenomena is called as consolidation. You can notice, students, here. You can notice. So this everything is mild haziness. So you can see only few haziness, slightly white, whereas on the other hand, what do you see here? More density. So what do you see there? More dense areas. This more dense areas are consolidations, whereas this mild haziness, it is ground glass opacity. You should be able to appreciate what is ground glass opacity, what is consolidation. Now what do you see here? So this is a honeycomb. This is a honeycomb where honeybees store their honey. Now if you look into the lung, can you see abnormal rounded areas of air at the periphery of the lung? Abnormal rounded areas of the air indicating dense fibrosis around the alveoli. So these are just similar to a honeycomb. Can you see this? Abnormal rounded areas of air around at the periphery of the lung. So this is similar to this image. This is called as honeycombing. This is called as honeycombing. This is called as honeycombing. Then coming to the pattern of involvement, mostly it is seen at the periphery of the lung. If you see, whenever honeycombing happens, it is more predominant at the periphery of the lung. At the periphery of the lung, what is present? Pleura. This type of involvement is called as subpleural involvement. This type of involvement is called as subpleural involvement. Now what is the disadvantage of having a abnormal rounded area of air at the periphery of the lung? See, any abnormal rounded area will be unstable, it can break. There can be chances of pneumothorax. We have discussed previously that in ILD pneumothorax can happen, in which it will happen whenever there is honeycombing. These honeycombing areas, abnormal rounded areas of air, are at the periphery of the lung. they can rupture at any point of time resulting in pneumothorax. Whenever I show this image, few students will get confused with crazy paving pattern of pulmonary alveolar proteinosis. See, the difference is very clear. In crazy paving pattern, if you notice here, the alveoli are filled with surfactant. So predominantly the abnormality will be white, whereas in honeycombing, still alveoli can be filled with air. So this abnormal rounded area, so still you can see more of black areas. So this is crazy paving pattern. Alveoli filled with surfactant. It is as easy to differentiate black and white. It is as easy to differentiate black and white. So this is crazy paving pattern, predominantly white because of alveolar filling with surfactant. This will be honeycombing. So never get confused between crazy paving pattern and honeycombing. They are completely different. Crazy paving is white predominant. Honeycombing is not white predominant. This is the difference. Now let us see pathological pattern. Write down, students, pathological pattern. Pathological pattern of ILD. Pathological pattern of ILD. We have usual interstitial pneumonia, called as UIP, non-specific interstitial pneumonia, NSIP, acute interstitial pneumonia, AIP, cryptogenic organizing pneumonia, COP. For your exam, these four are very important: UIP, NSIP, AIP, COP. Along with this, less seen in my clinical practice, respiratory bronchiolitis ILD, desquamative interstitial pneumonia, this is DIP, and this will be RBILD. Lymphocytic interstitial pneumonia, called as LIP, lymphocytic interstitial pneumonia. Let us see what is common. This NSIP is considered as most common ILD pattern, in connective tissue disorders. We know that connective tissue disorders can cause ILD. In that, most common pattern is NSIP, except there is an exception. In rheumatoid arthritis, it will be UIP pattern. In rheumatoid arthritis, it will be UIP pattern. Now if they ask you which is most common pattern overall, because it was usually happening, routinely happening, it was called as usual interstitial pneumonia. This is considered as most common pattern overall. In UIP, there is a subtype, UIP of unknown etiology, UIP of unknown etiology. It is called as idiopathic pulmonary fibrosis. It is called as idiopathic pulmonary fibrosis, also written as IPF. Many books use UIP and IPF as synonyms, but there is a slight difference. What is that? UIP of unknown etiology, it is called IPF. We will be discussing these 4 types in detail. For your exam, first 2 types, UIP, NSIP, the differentiation is very important. Let us try to understand this with help of a table. Make a table. On one side UIP IPF, on other side NSIP. I am going to discuss the clinical presentation. What will be the biopsy features? What do you see on the CT chest? And what will be the treatment and prognosis? Starting with UIP. UIP, it is seen in elderly males more than females, smokers. Patient will have chronic symptoms. There can be clubbing. If you put your stent, there will be fine crepitation. In UIP, within the biopsy, you can see classical areas of involvement called as fibroblastic foci. Fibroblastic foci seen. And this involvement will not be uniform throughout. This is called as heterogeneous pattern. It will not be same throughout. This is called as heterogeneous pattern of involvement. And on the CT chest, one can notice bilateral lower zone predominant disease. Bilateral lower zone predominant disease. You can see very less GGOs, minimal GGOs, but there is significant traction bronchiectasis. And honeycombing seen. There will be significant traction bronchiectasis and honeycombing seen. We will also discuss NSIP, then we will see the treatment. Coming to NSIP, this is seen in middle-aged females more than males, non-smokers, subacute symptoms, and on auscultation there will be fine crepitations. Here the fibroblastic foci are rare. There will be rare fibroblastic foci. Whatever you see will be more of lymphocytic inflammation. It will be more of lymphocytic inflammation. Now this disease is also bilateral lower zone predominant, but the important difference here is there will be significant ground glass opacities. There can be traction bronchiectasis because fibroblastic foci are rare. There will be very rare honeycombing. Now tell me students, out of these 2 for which I can give green badge indicating good prognosis, it is NSIP because it is only ground glass opacity. It has not progressed into honeycombing. So these patients will have good prognosis. Then what will be the treatment here? When you don't know what to give, what will you give in respiratory medicine? Steroid. treatment will be steroid. Whereas UIP IPF, already patient has progressed to honeycombing. Honeycombing is generally irreversible. Now whatever drugs available will also not reverse the disease. It can only stop further progression. What are those drugs? There are antifibrotics such as pirfenidone, nintedanib. This is extensive disease. Patients will have poor prognosis. UIP, NSIP, this patient deserves a red badge, poor prognosis. And what are the drugs that can be helpful to prevent further progression? We have pirfenidone, nintedanib, pirfenidone, nintedanib, pirfenidone, nintedanib. And if they ask you what will be the best treatment, already this is an extensive disease and drugs available cannot reverse the disease. The best treatment will be a lung transplant. Previously we have discussed most common indication of lung transplant worldwide. It was ILD. In that which pattern? It is UIP. UIP pattern presents with honeycombing, presents with fibroblastic foci, presents with poor prognosis. Now this is a very important table. You should know how to differentiate these two diseases clinically, pathologically, radiologically, treatment and prognosis wise. Treatment and prognosis wise. Let us see some images. By seeing those images, you should be able to identify. This is the first image. So in this image, what do you see? Can you see abnormal rounded areas of air at the periphery of the lung? What is this pattern called as? Honeycombing. What do you see here? It is a UIP pattern. When I am unable to know the etiology, it is IPF. Now next image. Here you can only notice mild haziness. This mild haziness, it is called as ground glass opacity, and where it is seen? In NSIP. Never ever, students, you should forget how to differentiate these two. See, very simple. You can see mild haziness. This mild haziness is ground glass opacity. Whereas here, in this image if you see, you can see all this abnormal rounded areas of air arranged like a honeycomb. This is honeycombing. This is honeycombing. Here also you can see the honeycombing. So this is ground glass. So here you can see this, everything is ground glass. Keep this in mind. This is ground glass. I will show you also honeycombing now. Can you see here, students? This part is honeycombing. See this everything is honeycombing. So you can see abnormal rounded areas of air just like a honeycomb. So honeycombing and ground glass opacities you should not forget. Honeycombing. So this everything is honeycombing. This everything is honeycombing. So this is ground glass. Only mild haziness, no much architectural distortion. So why I am stressing is, so these are some basic questions. If you are unable to differentiate honeycombing and ground glass opacity, it will be very difficult even in your clinical practice, because honeycombing generally indicates an extensive disease. Ground glass, if you identify early and if you treat it accordingly, patients will have very good prognosis. Next we have acute interstitial pneumonia. Acute interstitial pneumonia, AIP. Then we will also go to cryptogenic organizing pneumonia. Cryptogenic organizing pneumonia, COP. this acute interstitial pneumonia, the other name is Hammond-Rich syndrome. It is called as Hammond-Rich syndrome. These patients present with acute shortness of breath, hypoxemia, and bilateral diffuse pulmonary infiltrates. Bilateral diffuse pulmonary infiltrates. Where did you come across such a presentation, students? You have come across such a presentation in ARDS. This also presents like ARDS, but we don't know exactly what is responsible for that ARDS. So it is also called as idiopathic ARDS. Acute interstitial pneumonia presents like ARDS, but you don't know the exact reason for this. It is called as idiopathic. Treatment, generally it will be supportive. We have to ventilate and wait. Because you don't know what exactly you are treating, this patient will ultimately have mortality, high mortality. This is a severe presentation and you have no clue what you are exactly treating. So these patients will have high mortality. Coming to cryptogenic organizing pneumonia, three important features are seen here. This patient will have pneumonia like illness. Pneumonia like illness. If you take a biopsy, one can notice accumulation of granulation tissue, accumulation of granulation tissue in airway. This accumulated granulation tissue is called as Masson bodies. This accumulated granulation tissue is called as Masson bodies. Along with that, you can notice presence of interstitial inflammation. Presence of interstitial inflammation. Within the CT chest, you can notice bilateral consolidations. Within the CT chest, you can notice bilateral consolidation. And treatment generally will be steroid. Now why it is called as cryptogenic organizing pneumonia? There is granulation tissue. So write it here, students. This is accumulation of granulation tissue within airway. There is granulation tissue getting organized in the airway. So it is called as organizing pneumonia. The exact reason for this is not known. So it is called as cryptogenic. There is granulation tissue getting organized in the lung. So it is called as organizing pneumonia. The exact reason behind this is not known. So it is called as cryptogenic organizing pneumonia. But for your exam, students, most important will be the differentiating features of UIP versus NSIP. UIP versus NSIP. Coming to smoking and ILDs, introducing you the world's youngest smoker. So this fellow started smoking from his second year onwards. Now he is about 10 years old. He has stopped smoking. Why did he start smoking at a very young age? Nobody knows. Now don't concentrate on this picture, concentrate on this. This is important. Now what are the ILDs? Where smoking is considered as a very strong risk factor. We have respiratory bronchiolitis ILD, desquamative interstitial pneumonia, adult pulmonary Langerhans histiocytosis, acute eosinophilic pneumonia, pulmonary hemorrhage syndromes, idiopathic pulmonary fibrosis, See, in all this, we consider smoking as a very, very strong risk factor, students. Now my question is, are there any direct lung diseases where smoking is considered as protective? Write down ILDs. ILDs less prevalent in smokers. ILDs less prevalent in smokers. ILDs less prevalent in smokers. What should be your answer? First is sarcoidosis. Second is hypersensitivity pneumonitis. Sarcoidosis. Next is hypersensitivity pneumonitis. Students, many studies have shown that this sarcoidosis and hypersensitivity pneumonitis was not frequently happening in smokers. So they thought that smoking might be protective against these two diseases, but it does not mean in the treatment of sarcoidosis and hypersensitivity pneumonitis you should advise smoking. So that was mainly based on observation. Say, what might be the reason? Already smoker's lung is filled with so many diseases. As a discount, God must have exempted sarcoidosis and hypersensitivity pneumonitis. So here, this is the list of diseases where smoking is considered as a strong risk factor, and here we have list of diseases which are less prevalent in smokers: sarcoidosis, hypersensitivity, pneumonitis. Try to solve this question. A 75-year-old male referred for dyspnea and exertion chronic cough that have worsened over 12 months. PFT showing a restrictive phenomena, FEC is less, chest radiograph, patchy infiltrates, on the CT chest, honeycombing, lung biopsy, fibrotic foci. What is the most appropriate therapy? What can be your possible diagnosis? Now we are seeing elderly male, chronic symptoms, restrictive pattern, honeycombing, fibrotic foci. All these are suggestive of UIP pattern. If you are unable to know the etiology, IPF. In that, initial management will be pirfenidone. The best answer is option A. This completes interstitial lung diseases. Most important for your exam is how to identify ILD, various radiological patterns, and specifically differentiating features between UIP and SIP.